Hello, Christabel.
Hello.
Hello, I'm Lukman.
Hello, Lukman. How are you?
I'm fine. Nice to meet you.
Nice meeting you too.
Let me to share about the rules to the student first before.
No problem.
Okay.
No problem. Yeah.
Good morning, all students here. We hope you always be healthy, and it is the rule of our participants as a students here. Number one, please turn on your camera and turn off your microphone. Be sure your microphone is always off, and do not sleep for sure during this virtual lecture. And number three, question can be asked by chat menu, or you can direct and ask to Busiam as a moderator. And do not forget to subscribe YouTube channel. And in the end of this virtual lecture, it will be informed the URL of certificate issuance. So do not leave the Zoom. And last, the link is active for only 60 minutes after this virtual lecture is over. To all students, please pay attention to these rules. Thank you.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. I hope all of you are in the good condition. And thank you for joining in the two-day virtual visiting lecture. And today's lecture is a part of maternal and child health lecture. And today, we are pleased to have a great opportunity to have a great visiting lecturer, Christabel Yollanda Kambala, Ph.D. She is a senior lecturer from University of Malawi, and she's conducted many research about maternal and child health, about the quality, barrier, health financing related with the maternal health services. And she's also my friend, the same Institute of Public Health, University of Heidelberg, Germany. Yeah, but we are in the different research group, right, Christabel?
Yeah.
And
Yes.
yeah, and hello, Christabel. Welcome to Indonesia by virtual.
Thank you. Thank you.
Yeah, how are you, Christabel?
I'm all right. How are you, Lala?
Yeah, we are fine. Yeah, and yeah, and okay, Christabel, thank you for your willingness to give us a lecture and share your knowledge and experience our students, and maybe also my sorry, maybe the participant can turn off the microphone. Okay. And just for introduction, we are the Public Health Department, Faculty of Sport, Universitas Negeri Semarang, and we are located in the Central Java, in the Java Islands. And then, I don't know, there's from department or not, but I just can see lecturer, Prof. Wara. Assalamualaikum, Prof. Wara. Yeah. And okay, and today, Miss Christabel will sharing about maternal and child health, especially about barrier of maternal health service use. And as I said previously by email, Christabel, Miss Nursiam, the lecturer of maternal and child health for international class, will be your moderator in this lecture. And okay, and Miss Nursiam, please, your turn.
Thank you, Miss Lala.
Okay.
Assalamualaikum warahmatullahi wabarakatuh. Good evening, Miss Christabel.
Good. Yes. Good afternoon and good morning from me.
Yes. Thank you very much for your attending. Yes.
Thank you. Thank you for having me.
Okay. The Honorable Miss Lala, the Honorable the Honorable Mr. Lukman, and then the Honorable Prof. of Yawara, and all students in this meeting. Okay. First of all, let us thank you to Allah Subhanahu wa Ta'ala, because of His blessing, we are able to join in this meeting. Ladies and gentlemen, the virtual visiting lecture today is about barriers to maternal health service use, which delivered by Miss Christabel Kambala, Ph.D. She is a lecturer senior in University of Malawi. I am Nursiam, lecturer in Public Health Department, will be a moderator. Okay, let me read the agenda today. The agenda are the first session is opening from Ms. Lala Finis, and then the second session is presentation time, and then the third session is question and answer session, and then the last is closing. Okay. Please welcome Ms. Christabel Kambala. The time and the screen is yours. Please.
Okay, thank you so much for your warm welcome. Yes, just to share a brief introduction about myself in terms of my qualifications and the research interests, and also probably how I come in to as a visiting lecturer on maternal health services topic. My background is public health. I did my public health diploma in 1998 with the University of Malawi. And afterwards, I continued to do a B.Sc., a degree that is in environmental health. Then after the degree, I worked for about 2 years with the 2 NGOs. Basically, I was working on nutrition, working with mothers, especially pregnant women with their newborn babies, as well as children under 5. And from there, I came and joined the University of Malawi as a lecturer in around 2004. And from there, I worked for about 1.5 years. Then I went to do my Masters of Public Health in UK, that is in Glasgow University in Scotland. It was just 1 year training. Then I came back, continued with my work. And in around 2013, I did my PhD in public health as well, where I was together with Madam Lala in the University of Heidelberg in Germany, in the Institute of Public Health, now called the Global Health. And my PhD was so much looking at maternal health issues. We were conducting an impact evaluation of an intervention that was performance-based financing, and looking at how it improved maternal health care services in Malawi. Now, my strand actually focused so much on perceptions of women in terms of looking at quality of care. Now, that's where I come in, right? Because my research interests from then have shifted to looking at quality of maternal health care in the country. So I've done a number of studies on that. And today, my lecture will basically dwell much on sharing my experiences as examples, apart from sharing the facts that we have when it comes to maternal, newborn, and child health. And just to say that I will emphasize more on maternal and newborn health, not necessarily on child health. So we'll just touch here and there on the child health. Okay, thank you so much. Let me try to share my screen. Okay. Like we've already said, our lecture today is going to dwell much on barriers to maternal health service utilization. That's what we are going to zero in. Okay. And what should be our learning objectives or our learning outcomes? So by the end of this lecture, students, it's our hope that students will be able to identify the main indicators of maternal, newborn, and child health. We cannot talk about the barriers of maternal health service use when we don't know what is happening in terms of the indicators of maternal, newborn, and child health. So that's why we need to be able to identify the main indicators that are being used currently world over. Okay, and we will distinguish the different maternal and newborn healthcare services. In case there will be some participants that they may not know, and we are going to draw much on that, just describing these maternal health service, healthcare services, each one of them separately, and looking at the barriers, describing the barriers of each of those maternal and newborn healthcare services, the individual services. Then we'll try and explain or discuss how to overcome the barriers. Okay, so that's what we intend to achieve today. All right. Now, where do we stand in terms of maternal mortality ratio? Now, in terms of maternal health, the main issue is that we want to ensure that women have a positive pregnancy experience. That's all we want to achieve. But to see whether this is being achieved in individual countries, the measure or the main indicator that is looked at is the maternal mortality ratio. Okay, so the maternal mortality actually is the death of women while pregnant or while they are giving birth, during childbirth, or within 42 days after termination of pregnancy. Termination of pregnancy is in this case is after giving birth, or when you have maybe a miscarriage or a stillbirth, such things. So the health, the death of a woman during that period is actually counted. And it's an indicator of the well-being of women in a particular country or at global level. Now, in terms of the maternal mortality ratio, that is expressed by 100,000 live births, globally, currently, it's up about 211. We can see that there has been a decline in terms of the maternal mortality ratio from about 342. However, low-income countries or low-income settings, they still experience high maternal mortality rates. Of course, I should say here that there also has been a reduction in even individual countries, but still, even with that reduction in these individual countries, the maternal mortality ratio is still unacceptably high. So globally, on average, it's at 462, as opposed to 11 in the high-income countries. So you can actually see the disparities that are there. And it actually shows the disparities between rich and poor within countries, but also between countries, or the inequalities that are there in terms of access to services, but also use of services, okay? I don't know, I think I made some research for Indonesia. I think the maternal mortality ratio is now pegged at 177. It has also declined from about 230 something in around the 2010s. Okay, overall in 2017, about 295,000 women died from pregnancy and childbirth related complications. And 94% of these came from low resource settings, and 86% came from Sub-Saharan Africa and Southern Asia. So you can imagine the share that these countries are having. It's a huge, huge problem. For example, in Malawi, our maternal mortality rate is one of the highest, okay? And one of the highest in the world, which is ranking number 13 in terms of having the highest maternal mortality rate. Currently, it's actually pegged at 439. That is 439 per 100,000 maternal deaths. So you can actually see the challenges that we are in. But still, we are trying, because this particular, although it's still high, the interventions that have been there from the 1960s, 1990s have actually worked to our advantage so that the maternal mortality is actually decreasing. Now, we are also looking towards the reduction, towards meeting the global target of 70. So depending on the SDG, the Sustainable Development Goals, currently by 2030, the expectation is that at least the global target should be at 70. And that no country should have double this particular number. So we are on the right track. We just need more interventions to be able to attain these targets. So as you can see, between 2000 and 2017, maternal mortality declined. In Southern Asia, it declined by 60%. In Sub-Saharan Africa, where I come from, it declined by 40%. So we are on the right track, but still, we still have a problem in terms of our women, in terms of using health services. Okay, now what are the causes of these deaths in women? So we have both the direct causes, but also indirect causes. In terms of the direct causes, we have severe hemorrhage, that is bleeding, severe hemorrhage, which is the major cause of these deaths in women during pregnancy, but mostly during childbirth, when they are giving birth. So they can bleed severely, and in other circumstances, if they are not managed properly, they can die. And another issue is about obstructed labor, prolonged labor, obstructed labor, as well as the rupture of the uterus. That's also something that is dangerous and can cause deaths, and it's actually causing the deaths. We also have hypertensive disorders leading to severe preeclampsia as well as eclampsia. Talking of also infections, probably because of unhygienic conditions in our health facilities. Sometimes the women can actually develop some infections, and if not properly managed, it can end in death. And also abortions related complications. Usually it's because women are accessing unsafe abortion services. And because of that, if they are not managed, or if they don't go to the facility, to a health facility in good time, and even if they go to the health facility, if they are not managed properly, that woman or that particular case can end in death. Those are some of the direct causes of maternal deaths. But we also have indirect causes, mostly stemming from pre-existing conditions or pre-existing disorders that are in the woman or in the mother. So for example, in this part of the world, we have diseases like malaria, heart diseases, anemia, HIV, diabetes, and so many other conditions, medical conditions. These medical conditions, when they are already pre-existing in the woman, may actually aggravate the situation, and it can end badly if not properly managed. So as you can see, all these causes, all these direct and indirect causes require specialized care, require that the women should go and access care for them to be able to be managed. And where do we stand in terms of the child mortality? In terms of infant mortality, this is the death that happens in children that are less than 1 year old. There's also a decline. If we look at the global picture, we see that there's also a decline in terms of the infant mortality rate. Now, in terms of infant mortality rate, this one is expressed per 1,000 live births. So if you compare data from 2010 or before 2010 to now, there has been a global decline in terms of the statistics. So from 65, right now we are on 29 in terms of infant mortality rate. Under 5 mortality, there's also been a reduction to 38 deaths per 1,000 live births. The same thing with neonatal mortality. But now when we look at the absolute numbers, these numbers are still scary, because in 2018, for instance, about 4 million, that is globally, died in that particular year. Of course, this is a shift from the previous years, including the under 5 mortality, where 5.3 million were registered to have died in 2018. This is a shift from about 12.6 million in the 1990s. So we are on the right track, but still these deaths should not happen. Okay, so that's why we talk a lot in terms of how do we make sure that we reduce these mortalities. Nobody deserves to die. Okay, causes, the major causes of child mortality. The leading causes, for example, in 2017, the leading causes were the preterm birth complications. So now this is a picture of all the under 5 children, and the neonates take a portion on that, and the infants as well take a portion on that, like that. Even for the other years, they take a portion on that. But the major causes that were registered in 2017, and these causes have been consistent over the years and have remained, and we require to do something about it, are these ones. Majorly there are 5. So number 1 is the preterm birth complications. So usually this is the death of a child, not a child, but children, the pregnancy that is terminated actually before the woman, or before the pregnancy is actually to term. So every year, an estimated 15 million babies are born preterm. Okay, so if children are born preterm, usually they actually lack, especially in low resource settings, they lack cost-effective interventions or cost-effective care that may lead to their deaths. Because if a child is preterm, small, premature, they need probably warmth and interventions or facilities to manage these babies. Usually they're not there in low resource settings. For example, in Malawi, we have a number of interventions, low-cost interventions to actually curb that. We have what is called the kangaroo care. With the kangaroo care, basically, babies are carried by the mother to promote, they are carried in front of the mother and to promote skin-to-skin contact with the mother for warmth, but also for frequent breastfeeding. Because the other issue why babies die when they have born premature is the lack of support for breastfeeding. So some of the interventions that are working, for example, in Malawi, are such interventions. And then there's acute respiratory infections like the pneumonias and intrapartum related complications. This is also something that is big, especially when it comes to prolonged labor. Then issues like umbilical cord relapsing, all those things, umbilical cord prolapse rather. So where the cord is trapped against the baby during the time of giving birth. And these are the complications that are actually happening during the childbirth period. So those such complications also are leading to death, may lead into death if not properly managed. And we also have congenital anomalies. These are just birth defects, like for example, cleft palate or Down syndrome and many others, or even heart conditions. Babies may be born with such conditions. And in this part of the world, another leading cause of child mortality are diarrheas. So diarrhea is also something worth mentioning. And in Malawi, diarrhea is also a leading cause of deaths in under 5 children. Malaria as well is also a leading cause of deaths in under 5 children, not mentioning pneumonias and the like. So these are some of the things that we are concerned with when it comes to understanding why women are not going to health facilities. We need to understand the barriers or the issues that are preventing them from going to the facilities in order that we bring in interventions and encourage women to be using healthcare services all the time to avoid these kind of complications. Now, maternal and newborn healthcare services. These are services that are offered to women when they are pregnant but also when they are giving birth and even in the postpartum period. And also the care that is given to neonates. Then at first, as I said, I indicated that we are going to zero in much on the health of women during pregnancy, childbirth, and postpartum period, as well as the health care of neonates. Now, a neonate is just a newly born child and who is still under 28 days of age. That's a neonate, a newborn. Okay. Now, there are 4 essential care elements worth noting. The first one is the prenatal care. Prenatal care is very important and very crucial when it comes to making sure that we have positive health outcomes in the mothers or in the women. So prenatal care entails regular checkups or conducting antenatal visits to health facilities for monitoring the health of the mother, but also of the unborn baby, the fetus. And another essential element is the issue of skilled care attendance. So skilled birth attendance is also something that is very important, where facilities need to have emergency backup, such as facilities, but also skilled doctors, nurses, and midwives, so that they should be able to manage the deliveries, the normal deliveries, and also they should be able to recognize onset of complications. So if a birth attendant is skilled, they are trained to be able to recognize these particular complications, and they have tools that they use to be able to do this particular kind of work, especially in terms of recognition of onset of complications, like the use of, some of us may know the use of barograph and everything else that goes with it. So that's why an essential element here is like the skilled birth attendants. Women should at least be attended in the presence of skilled birth attendants. And another essential care element is the emergency obstetric care. This is very important as well. Just having skilled birth attendants is not enough, but you also need to have facilities that will enable you as a healthcare provider to address these particular problems that may arise during the time of birth. So for example, the causes of deaths or the causes of maternal mortality, maternal mortalities that we explained earlier on can be addressed at a facility that has emergency obstetric care facilities as well. So they should be able to manage hemorrhage, to manage infections, to manage abortion complications, hypertensive disorders, and even obstructed labor. So having a skill only is not enough, but also having facilities to be able to manage a woman is also important. Then after the birth, postnatal care is also important. So that's also an essential care element. Now, we are going to spend some time looking at this in case there may be some participants that may not be aware of what happens during these services. So let's start with the antenatal care. In terms of antenatal care, WHO, this is World Health Organization, recommends that a woman should make not less than 4 antenatal care visits. Okay, so this is very important in terms of use of antenatal care visits, because this is the time where a woman can be assessed and prevent the risk of adverse obstetric outcomes. So services that are offered during the antenatal care, for example, a woman is examined, physically examined or screened for various problems, and assessing whether they are at risk. For example, if the pregnancy is high risk, if they are carrying twins, if they have any defects, if they have any complications that are actually already seen, they can be identified during the antenatal care, and proper management or proper referral can be made. Usually this is also important when we are using, or when women are using low-level facilities. So during the antenatal care, they should already make a decision to say, your delivery is going to take place at a higher level facility. And this can only be observed or seen if a woman is faithfully attending all the antenatal care visits that are required. So in total, you need to make about 8 visits. That's the recommendation. But if you can't manage the 8 visits, as we will see later because of a number of challenges, at least make 4 antenatal care visits. So during the antenatal care service, women are also counseled on different topics of importance. That was also going to act or to inform the particular woman in terms of how they can prevent other diseases and avoid other major risks to the pregnancy. For example, counseling on HIV issues, counseling on malaria, TB, and every other conditions that may aggravate the situation of the pregnancy situation and end in complications. So this is also the time where a woman can get some immunizations as well against certain diseases. So the whole idea is to reduce complications during childbirth, but also just reducing complications during the time the woman is pregnant. Now, where do we stand in terms of antenatal care service utilization? Globally, the prevalence of antenatal care use is pegged at 78%, right? And for antenatal care use, globally, we've seen that about 86% of the women, they attend at least 1 antenatal care, right? 1 visit. And 65%, they at least attend 4 visits of their antenatal care. However, 6% go into labor without having attended any ANC visit. And these are women that actually may be at risk because they haven't been assessed through the time that they were actually pregnant, okay? And another important point to note is the late initiation, because the recommendation is not just to make the 4 visits, but also to start antenatal care in good time. Now, late initiation, or if we start late, it may also bring in some challenges as well. So globally in around 2018, 60% was registered of the women. It was registered that 60% start very late in terms of initiating their first antenatal care visit. Just to share our statistics in Malawi, in terms of antenatal care use, women that have used at least once this particular service, they're about 90%. So you can see that we are on the right track in terms of at least using the service. But the challenge is these women are starting late. These women are starting late. So we may be too late to intervene. There are a number of reasons associated with starting late. And these reasons are shared in a number of countries, not only in my country, Malawi, but also in other low resource settings. There's usually secrecy in the early stages of the pregnancy. I don't know whether this is also the case in Indonesia, but in Malawi, there's usually secrecy in the early stages of the pregnancy. People don't want to know, because it's a cultural belief anyway. People don't want others to know that they are pregnant for fear of being bewitched, or when they will be bewitched, they may have a miscarriage, all those things. But also sometimes women may prefer traditional care before they go to the conventional medicine. And in cases where the pregnancy is unwanted, or where the pregnancy is out of wedlock, a woman may be contemplating abortion. That during that period where a woman is contemplating abortion, or they are getting advice from peers, advice from family members, or wherever they get the advice from, that's the period that they are delaying to go to the facility to start their antenatal care. So that is also a big issue. Another issue that studies have actually shown is the fearing of antenatal care HIV test outcome, because it's also recommended that during the antenatal care, especially during the first visit, a woman should be tested for HIV, apart from the other disease, because for STIs, they are actually tested, including the HIV. So when a woman has those particular fears, they don't want to go early for fear to say, what if I'm HIV positive? How am I going to take it? That's why it's also important to have specific interventions on HIV testing when it comes to pregnant women, because usually this, like for example, in my country, Malawi, the HIV test that is conducted at the health facility level, it's called provider-initiated test. Provider-initiated test. Now, when it is provider-initiated test, this is not something that has been decided by the woman. But still, on the other hand, it's the right. The unborn baby has got the right to be prevented from HIV. So because we have interventions that are in place, for example, the prevention of mother-to-child transmission, it's very important that women get tested. But still, we need to do a lot of awareness on that so that women should accept that that test is important, not only for them, but also for the unborn child. Okay. All right. Now, what are the major barriers to antenatal service use? Major barriers are travel cost to the clinic. Most women who travel, especially those that are in the remote areas, in the rural areas and remote, hard to reach areas, travel cost may be a hindrance. They have to travel long distances by foot, and distance can be a hindrance, but also if they are not traveling by foot, they will use motorized kind of traveling, and that becomes costly as well. So this becomes a barrier. So we have a number of studies in a lot of countries that have actually established, they have corroborated and found that this is a major hindrance to service use. Another barrier is lack of partner support. Lack of partner support is also something that is very important, because the recommendation, like for instance in my country, during the antenatal care visits, it's recommended that you go together with a partner. So whether it's a husband or whoever is a partner, you have to go together to use the service. Now, when the other part is not supporting you, that becomes a hindrance, because in other facilities, for example, during the first visit, they need to conduct HIV testing for both of you. So your male partner and yourself, they need to conduct a HIV test. So if the partner is not coming, sometimes the facilities may not give you the care you're needing. They may actually tell you to go back and bring your partner. So this becomes a hindrance when the partner is not available. Another issue is shortage of staff. This is very common, as we are going to expound this more when we come to child health, delivery care services. But shortage of staff, this is something that is a huge outcry in a number of countries, right? And it brings disparities in terms of service use, but also the indicators, because where there are shortage of staff, where there are low members of staff, especially skilled members of staff, skilled providers, chances are women are not going to use that service. They're not going to go to a facility where they're not going to be attended to by a skilled provider. Another issue is about overcrowding at clinics. There are a number of clinics that are usually overcrowded, and this can act as a deterrent. If you always go to a clinic that is too overcrowded, it has a lot of patients, you tend to wait long periods, or you tend to stay there for a long time, even spending the whole day. And this becomes a deterrent for service use. Next time, before you go, you are going to contemplate and think about how much time you spent the last time you were there. So this becomes as a deterrent. But also something interesting is the need to balance work commitments or income generating activities. So women want to balance. They are actually juggling to say, should I go? If they are not experiencing any difficulties with their pregnancy, they would rather go to do their daily income generating activities than go to a facility. So they are more committed to that. And this also actually points to the fact that if a woman is not aware of the pregnancy complications that may arise during the time they are pregnant, they're not going to value this. So in case they're going to value generating income over their health. So this actually calls for maybe more health promotion activities, more awareness to the women for them to accept and realize the gravity of the problem. And also refusal of care for coming without authorization letter. This one, it's an interesting finding in 2018. This was actually studied in Malawi, where it has been established that other women are refused care when they come to the health facility. Why? Usually these are women that got pregnant out of wedlock. Now, in terms of the culture and the traditional values, the health system, firstly, tried to work with the, to have like community engagements to be able to at least bring in some bylaws and the practices that will encourage women to go and use care, right? So the health system together with the traditional leaders are working together. And there are a lot of bylaws that are actually positive, right? I'm going to share them later. But apart from that, there's something negative that is coming out of this. Because of the traditional beliefs that are there, or the traditional values that are there, to say that when a woman gets pregnant out of wedlock, they have shamed the village or they have shamed their community. Now, if they want to go to a health facility, they have to be attended to with permission from the traditional leaders. So this traditional leader has to write an authorization letter to say, although because we are also encouraging male involvement. So the partners should come with them. Now, when they see them coming without a partner, they should just have at least an authorization letter to say that, okay, we haven't been, the woman doesn't have a husband. That is a pregnancy that was got out of wedlock, but please assist them. So sometimes they are refused care, which is also, this particular blame can be shared by both the government policies, the health workers, but also the traditional leaders. Because in a way, this is acting as a deterrent to service use, because if a woman finds herself in that situation, they're not going to use care. And another barrier is negative behaviors of health providers. So if a health provider is rude, is verbally abusive, others actually are even physically abusive to the women, that becomes a huge deterrent to service care. And recently, there has been a lot of talk and interventions as well as the policies actually focusing on how to promote respectful maternal care. And this is stemming for the negative behaviors that are actually experienced by women when they go to seek care in these facilities. So that's it about antenatal care. Let's move to delivery care. Skilled birth attendance. So this is professional medical and surgical care for pregnant women, which with a special focus on delivery and as well as the immediate postpartum period. So health facilities, they should be able to have facilities for surgery in case of complications. They should be able to provide intravenous oxytocin. The intravenous oxytocin is very important in the management of severe bleeding. Okay, when there's what is called postpartum hemorrhage. So at least the women should be able to get that. And also availability of other medical treatment to treat infection, anemia, preeclampsia and eclampsia, the hypertensive disorders of pregnancy. But also the facility should be able to have facilities for blood transfusion, for manual procedures, but also just the general monitoring of labor and management in pregnancies. And another important issue or another important facility is to be able to conduct manual vacuum aspiration. Much as most countries are against abortion, but women are conducting the abortions secretly, okay? And usually these are unsafe abortions. So facilities should be able to have to have at least equipment and supplies to be able to assist a woman or a girl when they come to the facility, if at all they had unsafe abortions. So the manual vacuum aspiration usually is there to help in terms of management of such kind of cases. And of course, facilities should be able to offer special care for newborns, the neonates. Okay. Now, in terms of service use, the obstetric healthcare service use, this is for skilled birth attendants. In 1981, in 2019, 81% of the births were reported to have been assisted by skilled health professionals, meaning that the other percentage is still using other unprofessional or unskilled health providers, and that becomes a challenge. And probably that's the percentage that is contributing towards an increase in maternal mortality globally. And coverage of skilled birth attendants is 60% in sub-Saharan Africa and 77% in Southern Asia. Now, the other challenge is, much as we have put aside or put in place interventions to encourage women to go and deliver in a health facility, we still have a challenge in terms of healthcare professionals that are available. We still have a shortage of staff in these facilities. So the question could be that should we say that if a woman goes to a health facility, they're going to get skilled care? That is also a question that we can leave it aside for a discussion later. But this is what is happening. Just to share statistics in Malawi, in terms of skilled birth attendants, we are also doing well. We have moved from 71% in around 2010 to now 90%. So 90% of the women are using skilled health professionals. In other words, they are going to the health facility to be attended to by professionals. Now, there are a number of interventions that have actually made it possible for us to have that nice percentage, because 90% is, almost everyone is going to the health facility. So first of all, we have bylaws, like I said earlier on, that we are working with cultural custodians, with traditional leaders in terms of bringing in other interventions at community level to encourage women to go and deliver at a facility. So the first thing that happened in around 2010, there was a ban of traditional birth attendants. So traditional birth attendants were banned in around 2010 to conduct deliveries in the community. Of course, at some point, because of the political interferences, they wanted to bring them back. They wanted to start practicing again, but then the professionals actually had to vehemently decline to say, no, we cannot go back to that. So that has actually worked, but also the bylaws that are there at community level. When a woman delivers in the community without the care of a skilled health professional, they are actually penalized or they are sanctioned. So they pay a little something for doing that. Now, in Malawi, in my country, Malawi, we are talking of an ordinary citizen, an ordinary woman who lives under $1 a day. Now you are fined probably $2 or $3. That's something, and it becomes a hindrance. A woman doesn't want to deliver in the community for fear of such sanctions. So we have seen a lot of women going to health facilities to actually seek care. So when you deliver in the community, or even when you deliver on your way to a health facility, you are going to be sanctioned. So the fact there is women should also go to the facility in good time. Okay. So in using these community engagements and several other interventions, we have actually seen that in terms of use of care, we have at least increased the use. Now, when you compare other regions of the world, like Central Asia, Eastern Asia, Western Asia, North America, Europe, in these countries, our friends have already achieved universal health coverage. So everyone, in terms of universal health coverage, everyone, all are able to access care. They also are accessing care of high quality without incurring financial difficulties. But in this part of the world, like in my country, Malawi, we still are struggling on that, but we are striving to bring in interventions so that we also achieve universal coverage. Okay. Now, maternal mortality is actually associated with 3 delays. Not going to the health facility, or even going to the health facility, but not getting the care that you need. So this is also a hindrance in terms of health service utilization. There's this popular model that was developed, and it has been applied by a number of scientists or even programmers when it comes to bringing in interventions. So we have what are called the 3 delays. So there's the first delay is a delay in decision to seek care. Usually that is affected by socioeconomic and cultural factors. So not going to the facility in good time because of other socioeconomic factors that we are going to look at later, and also because of cultural factors. That's the first delay. A second delay is now you have started off from home, going to the facility, now a delay to reach care. So accessibility facilities. And the third one is the delay in receiving care, hinged on quality of care. Now, let's start with the delay in deciding to seek care. Usually, low status of women with poor understanding of complications and also risk factors, they don't really value their health, as I said earlier on, and they don't even understand the risk factors of pregnancy. They will delay to seek care. They will take their time, okay? And in terms of the low status women is because of the financial burdens that they may have, they may not go to seek care in good time because they are just dependent on others, right? First of all, they are dependent on others to make a decision for them to go to the facility. In this part of the world, like in my country, sometimes they'll wait for a marriage counselor, somebody who is at least highly esteemed in that family. Those are the people that will make a decision for them to go to the facility. In so doing, if the person is not there, you are going to delay. Or if the person is there and they don't want you to go to the facility, for whatever reason, you are going to delay. So women with low status are also affected in that way. If women are empowered, if women are trained, if women are educated, this may actually change and this delay may be addressed. But also previous poor experience of healthcare. If they had poor experience of healthcare, they are not going to go again, or they are not going to go in good time. Acceptance of maternal death, that is an obvious thing. If I just accept that we can die or not, whatever happens, let it happen. That also causes delay. And for sure, financial implications. So financial implications in terms of cost of travel to the health facility, one. But also, I'll give an example of our policies, not policies, but the health policies, the health facility policies that are there in terms of women coming to give birth in the facility. There are a number of things or supplies, items that are needed by a woman when they are coming to the facility because of our difficulties in terms of finances at government level. The burden is now pushed to the women. So when they are coming to the facility, they need, if you look at their delivery bag, you compare it from somebody in a high income country, you'll be amazed because they need to carry a basin, right, for birthing the baby when they are there at the facility. They need a plastic paper, a plastic sheeting. That plastic sheeting is used as a Macintosh, but that has to be provided by the woman herself. They need to have clothes for the baby or wrappers for the baby. Everything that is to do with a baby, it has to be provided by the woman. And actually, when trying to mobilize these items, that may cause some delays. Okay, and that's what we've observed in a number of facilities. Now, when you go to a facility, without that, you're not going to be given because these facilities, especially the public facilities, they don't have such things. Yeah, so that's something to consider as well. Delay in reaching the healthcare facility due to distance to healthcare and hospital, due to availability of and cost of transportation, but also due to poor road infrastructure. This is very common in the rural areas or hard to reach areas, but also geographical barriers as well. Mountainous terrain, where in other countries we are talking of islands or rivers, and anything to do with the geographical positioning of where you are and the healthcare facility. This is also something that is acting as a deterrent. And you find that there are other areas where even the motorized transportation is not available because of the poor road infrastructure. So a woman has to travel by foot or has to use other means for them to reach a healthcare facility. So this actually becomes an issue or a challenge when it comes to using care. And the other delay is in receiving adequate care when they are in the health facility now. Now you've struggled to get to the facility using the 2 delays, right? Now the other delay is now when you reach the health facility. So in the past, most of the interventions have concentrated or they have focused much on addressing the first 2 delays. The third delay has recently been focused on, but it was neglected. So it's actually looking at the delays or the quality now of care that is provided in the facility. So you find that most facilities, especially for the public facilities, they have inadequate medical equipment or even essential medicines. That becomes a delay. So if a woman already has come to the facility when they are in labor or when they have developed complications, a skilled birth attendant may have the knowledge on how they can actually manage that particular case. But because they lack equipment, it becomes a challenge. I know a number of skilled birth attendants that each and every day struggle, and others have become innovative and bringing in their own, improvising their own equipment, but they cannot improvise every equipment, right? But they are doing this just so they save a life. So this is also something that is worth noting: inadequate medical equipment as well as essential medicines. And we have infrastructure challenges as well. The maternity wings, how are they? At some point, I think we are going to share that. But for my country, Malawi, how the health system is structured is we have the primary level and we have the secondary and tertiary level. So in the primary level, we have the health centers. We have a lot of them, right? Although they are not enough, but at least we have those, and these are public facilities. In our facilities, we don't pay. It's a free service. There's no user fee. But still, we have infrastructure challenges in terms of the supplies that we talked about, but also the physical buildings themselves. For a labor ward, for a standard health facility, the labor ward can only take 2 women at a time. So 2 women that are in labor at a time, or 3. In other facilities, it may be 4, but usually on average is 2 women. So what happens is you find that 5 or 6 women are in labor at the same time. It becomes a challenge to manage such kind of situations. So health workers are struggling because of that, and infrastructure challenges. This is something that we need to address as well. Shortage or low numbers of skilled staff. Usually you find that there's only 1 skilled worker, and that skilled worker, in the studies that I've been conducting, you find that there's only 1 skilled worker working day and night shift. And they give, in fact, it's not a day shift or a night shift, but it's day and night shift for 1 person for a week, and they exchange with another one, because usually these health centers are understaffed. So they've made their own arrangements to say, I can stay here for a week, then you come for another week. I rest for a week, then you come for another week. Now, in so doing, this is not a government policy, but this is just something that they've arranged themselves. But in so doing, women are actually suffering, because in the end, 1 person is overwhelmed in conducting deliveries. In one night, they may conduct about 50 deliveries. So 1 person against 50 deliveries, they will be exhausted. And in the end, you find that women have come to the health facility, yes, but they are helping one another, right? They are not assisted by a skilled health worker. But also another issue is about negative attitudes that we talked about earlier on. And we also have high informal costs of essential medicine. Like I've already said, we don't have a user fee in our public facilities. But if you want to get good care or timely care, sometimes there are all these informal payments, and these things are happening. If you don't have that, you may be delayed in terms of getting the necessary care that you need, but also limited capacity to provide care because of maybe qualifications as well, and also deficient referral system. That is also something that is bringing in delay. So for example, I said that in the low-level facilities, if they need comprehensive emergency care, they have to make a referral, right? But usually they don't have an ambulance on standby. Several health facilities are sharing 1 ambulance, so transport will be a problem. It will take time for a woman to actually reach the desired care. So these are some of the issues that are very important to note as well. In the postnatal care period, this is period following delivery until 6 weeks after birth. And it is recommended that a woman and a baby, whether a woman has a live baby or the woman had stillbirth, all those things, at least they should attend postnatal care 24 hours of birth, within 24 hours of birth. And they should also receive additional postnatal care visits. Now, this is an issue world over, because in terms of postnatal care usage, it is very low. It is very low. So less than half of women receive postnatal care visits within 2 days of childbirth. This is in the sub-Saharan Africa. Now, if others, there's a study on the demographic health survey where they used demographic health survey of 23 sub-Saharan Africa, where others have delivered at home. Even those that have delivered at home, they don't come for postnatal care. And just in 2019, they found that only 13% who delivered at home received postnatal care within the 2 days of birth. This is also something to take note of, and this is also something to to be considered when it comes to interventions to address maternal mortality. Because during the postnatal period, that's the time other complications may also, even though they were not there, they may actually arise during the postnatal period. Now, the barriers, mostly in general, the barriers are shared. So most of these barriers, we've already talked about them when we're talking about the antenatal care service, but also skilled birth attendants. So I'm not going to spend time looking at those. Now, these are the barriers. And there's an agreement to say these are the major barriers. I know there are several other barriers that we may not have touched on, but these are the major barriers that are there. Now, what do we do? What do we do? So we need innovative approaches to delivering maternal and newborn health interventions. So there are aspects of the health system that we need to improve. We need to improve the supply side. We need to improve the demand side. We also need to improve quality and create an enabling environment. So improving provision of services can be done. Improving use of services can be done and has been done. There are a lot of interventions on that. Quality is also, like I said earlier on, a few minutes ago, to say new interventions now, we have focused on improving quality of care. Yes, we are doing that, but all these require to have an enabling environment. We cannot do things without having strategies or policies in place. So that's what the enabling environment will mean in this case. So what are the supply side determinants of health system? So these are aspects of the health system which relate to the production of health care. So there are two major things. There may be more, but there are two major things that we need to do. We need to make sure that services are available. And it's not just services. These services should be quality services with skilled birth attendants. And these birth attendants should also be motivated, because studies have actually shown that when health providers are not motivated with the cash, kind, or even just motivating them for performing well, if they're not motivated, they don't actually perform well as well. And it may also cause disrespect in terms of offering their services. So we need to have services that actually have such things in place, in good place, enough skilled birth attendants, but also well-motivated birth attendants that are offering respectful maternity care. The infrastructure should be looked into. We need to have equipment, drugs, and supplies. Now, in terms of accessibility, these facilities should be geographically accessible. We need more facilities, even in hard to reach areas. Let's put in facilities so that women find it easy. They work within a reasonable reach, but also the services should be financially affordable. Okay, there are a number of interventions that are put in place in terms of financial, to make the service financially affordable. On the demand side, then we need to improve those aspects that are operating at the individual level, household, but also community level, which influence the ability of an individual to be able to identify illness, willingness to seek care, and also to use appropriate health care. So acceptability coverage should be increased. People, women, as well as all the dependents, all the decision makers should accept, right? Should accept the service. But also contact coverage, the number of women that are actually using the service, we need to increase. And also effectiveness coverage. This we are now talking in terms of interventions that are there and that have proved to be effective. That coverage needs to be improved, because we have a number of studies that have actually shown to say some interventions are working well. So let's adapt and adopt and roll them out, all those effective interventions, whatever can work in our settings, so that we increase coverage on effectiveness as well. All right, if we want to specifically address delays in seeking care, we need to provide communities with information. They have to be well informed of the risks of pregnancy. Women should be empowered to be able to make their own decisions and also being able to be financially independent. Others have used income generating activities so that they can have money for that. They are using even village banks and everything else that can enable women have their own money, not depending on somebody else. Then to address delays in reaching care, that requires improving access to health care, provision health facilities, but also we need to have outreach health workers. If we cannot manage to bring in health facilities close to the communities, we can have outreach health cares visiting the villages, visiting households. And in my country, we have built maternity waiting houses or waiting homes where a woman comes when the pregnancy is 8 months old to wait, especially for those women that are coming from hard to reach areas or from remote areas. They come and wait until they are due date. Of course, it has a lot of pros and cons as well. Provision of motorbike ambulances in places where ordinary ambulances like cars can reach. In other areas, they are using motorbikes, right? So these are some of the interventions. There may be many more interventions. In fact, there are many more interventions, but for today, that's what we will share. In terms of addressing delays in receiving care, we need more health workers, we need equipment, we need the effective referral systems, and also promotion of respectful maternity care. What is the global response currently? The SD3 target is to reduce maternal mortality rate to less than 70 per 1,000 live births, and that no country should have a maternal mortality ratio of more than twice the global average. So they're using evidence-based programmatic guidance. There are global standards that are adapted by individual countries, putting their own standards that they can manage, but also WHO provides technical support to all the member states, to which Malawi is a member. I don't know if Indonesia is part of that. And another important thing is addressing inequalities in access to care and quality of both reproductive, maternal, and newborn healthcare services. Reproductive healthcare services is also something that we need to address because the maternal care, maternal health starts in preconception. So we need to have services in reproductive and sexual health, but also ensuring universal health coverage that are comprehensive. All women should be able to have access to care, have access to quality care, and they shouldn't incur any catastrophic expenses. Strengthening health systems with the quality data, but also ensuring accountability. People should be accountable for all these deaths. So you can have the maternal death systems that are there in terms of to make providers or even health facilities account for the deaths and improve their quality of care. And those are the global strategies in summary: improving skilled birth attendance, providing post-abortion care, improving family planning, and providing adolescents with better reproductive health services. This is something very important because 15% of the deaths of the maternal mortalities that are happening globally, the adolescents are actually contributing 15% of that. So we also need to have strategies in terms of addressing issues in adolescents. Okay, so this is the end of our lecture. I hope I managed to stay in an hour. So what we have done today is we have identified the major or the crucial indicators of maternal, newborn, and child health, and we zeroed in to distinguish what these maternal services are and described the barriers and briefly explained how these barriers could be overcome. So I hope we have achieved this for today, and I hope we have experiences or we have stories to share in terms of what we are doing in Indonesia, especially on the barriers to maternal and newborn health services, especially on the major issues that I may not have touched to, or I may not have touched on. Okay, thank you so much. I wonder if there are questions before we go into discussion, or we start with a discussion, then it's going to be a question and answer session. I'll leave it to maybe Lara to decide.
Thank you, Ms. Christabel. Welcome, Ms. Dr. Ika and Ms. Ainun. And then we are come to question and answer session. We have 7 questions from the student and lecturer. I will read the question. 1. What can be done maternal child and health program in pandemic situation in Malawi? From Puput Arisma. She is a student of public health UNES.
Okay.
Yes, please. Yeah.
Should I take it? Okay, so the question is, let me repeat the question just so I've understood it well. What can be done in Malawi in the pandemic situation in maternal care, that is?
Yes.
Okay. At the moment, it's quite challenging because the maternal gains that we have made over the years, we seem to be losing them because of the pandemic, especially this COVID-19. What has happened is not many people are using care in this particular pandemic for fear of contracting the virus at the facility, but also because of the restrictions that are there with the social distance things and everything else. The facility can only take a few, right? Because at first, our facilities have always been overcrowded. Now the facilities were taking just a few at a time. For example, in the morning, they would take about 100 and in the afternoon like that, depending on how much the facility can take. But what we have seen is there has been a reduction in increase of maternity care use because of the COVID-19. Now, what we need is to have interventions after the pandemic to bring in. In fact, we have somebody who would like to do her PhD to see how we have lost the gains that we had in the past because of COVID. So we are going to see how much we have lost, but certainly interventions to bring in. Right now, our health workers, especially the preventive care workers, are still encouraging women to go to the facility, even in the presence of the pandemic. The only challenge is long waiting hours.
Thank you, Ms. Christabel. The second question from Dr. Arulita Ika Fibriana. She is a lecturer in epidemiology department. I want to ask to Ms. Christabel, are there any data or research that shows barriers to use antenatal care facilities during the pandemic of COVID-19 and its impact to complication during pregnancy, childbirth, or puerperium phase? Thank you.
Okay, thank you so much for that very good question. I wouldn't say that data is available, but we are collecting data. Currently, we are collecting data to measure the situation, and most studies we should be concluding by the end of this year. So by the end of this year, we should definitely have such kind of data. And that's something that has also attracted attention of most epidemiologists. So that data will be available by the end of this year, I'm sure.
Okay, thank you, Miss Christabel. And then the third question. Hello, my name is Muhammad Rizky Darmawan, a student of Public Health Department. I have a question for Miss Christabel. We know that education about maternal and child health considered as important. So, in your opinion, what media can be effective to deliver this material to the low educated environment? And who's the target beside the mother? Thank you.
Yeah, that's also a good question. I'll just answer it based on what we have done before. Okay, so it's very difficult to especially to educate women with low education in relation to maternal health issues. So materials that are being used are simple materials. For example, we use posters, right? But mostly what we have used is to use mother groups. We have what are called mother-to-mother groups. So these mother-to-mother groups, they are like peer educators, right? So these are actually, in terms of their level of education, is a bit higher. Probably they have a secondary education than the rest of the community. Others have not gone to school and the like. But these mother-to-mother groups, we are using them for a number of services, including the maternal care services, where their peers are actually used to teach them and to actually use what we call the positive deviance, giving them a good example to say in the same community, we have this particular mother who has managed to have a better health outcome. What did they do? So learning from what others are actually doing. So yes, we are using some kind of discussions, but also when conducting these discussions or even awareness in these particular communities, we are using these mother groups. And we also have, we are also using the tradition, those ones who are practicing as traditional birth attendants, because these are valued members of the society. So the traditional birth attendants can also have been given another role to be able to educate their fellow friends. So in a nutshell, that's what I can say in terms of what we've done or what we are doing, but there are also many other interventions. Thank you.
Thank you, Ms. Christabel. And then the next question. Hello, my name is Salma. I want to ask, okay, I have read that there are more pregnancies during the COVID pandemic than normal. Then how do we handle it? Because there are certainly more cases of child and maternal mortality than in general. How can we prevent the mortality rate for mother and child from becoming high as well? Thank you.
Oh, thank you. That's another challenging question, I would say. Yeah, indeed. And I'm glad to hear this coming from Indonesia, because we are getting worried in Malawi as well. During the pandemic, we have experienced a lot of pregnancies, especially in adolescents. It has been huge, yeah? So currently, what we are doing is to establish what might have caused this, okay? What might have caused this? But of course, anecdotally, we know that girls were just staying at home and they had all the time and they had the conducive environment for such things to happen. Other pregnancies out of ignorance, but other pregnancies maybe because of abuse and all that. So the interventions that are going to be put in place are to address such issues. What we are going to find as causes of high rate of pregnancies, especially in adolescents, we are going to formulate interventions based on our findings. We have one district that has registered, the whole Malawi, that has registered highly in terms of teenage pregnancies during this pandemic. And we have a number of interventions, the sexual and reproductive health interventions. But in terms of trying to prevent further maternal deaths, right, from them becoming high, then we just need to provide the quality, high quality care to these women, especially the girls. Because usually when adolescents are pregnant, in other healthcare facilities, especially in remote areas where they have all these cultural beliefs, they may not attend to these particular girls. But what we need is to educate them, make them aware of effects of pregnancy, complications of pregnancy, so that they start using care early, but also using quality care as well, and promising them to go back to school. There are other NGOs that are even have come forward to assist such girls to put to birth, to have a good experience during their pregnancy, but also have enough resources to take care of themselves and their unborn baby. But it's going to be a challenge, I can tell you.
Thank you.
I hope
Okay, the next question from Miss Lala. Hello, Miss Lala.
Yes, I'm here.
Okay, yes, please.
Okay. So I have to ask directly. Okay. How's the health financing system in Malawi, and is there any health insurance for government, maybe the national health insurance, maybe, or if yes, how the coverage of the insurance for the maternal and newborn services in Malawi? Because yeah, cost is one of the barrier of the health service use.
Mm-hmm. Okay. Thank you, Ms. Lala, for that good question as well. What I can say is, I think I mentioned this during the presentation to say in our public facilities, we don't have any insurance. The services are free, okay? Now, even for maternal care services, they are also free. How we have structured our facilities as well, our health services, we have public services, we have private health services, and we have private for-profit health services. These are private facilities that are making profits. Then we have private not-for-profit facilities. Usually, these are run by religious institutions, okay? So we call them Christian Health Association of Malawi. So these are also good facilities in terms of making referrals and the like, the private not-for-profit facilities, also known as the CHAM facilities. So we are saying that the public facilities are free, but there are other areas where they don't have these public facilities, rural areas, and the facilities that are closest to them are these religious facilities. So what is there is the government has gone into what is called service level agreement, where they will take a certain percentage of the women for free, and the government pays for that in those facilities. So they may take 80% of the women. So the 20% can pay for their own services. Yeah, so insurance is there, but it's a private insurance. So people from probably high socioeconomic status are the ones that can buy their own insurances. But from the government side, we don't have that. Of course, there are a number of organizations that would want to introduce the insurances at community level to curb the issue about cost of traveling, covering the distances, but also we may say that our healthcare is not, we don't pay any fee, but when you are there, you incur some costs, upkeep. Okay, so such can be a deterrent. If you don't have costs for the upkeep, can be a deterrent. So there are a number of organizations that are looking into that. We also had Professor Manuela De Allegri. She also did some studies on that and made certain recommendations on how we can go about introducing such social insurances. Yeah.
Okay. Yeah.
Thank you, Miss Christabel. I think this is the last question.
Okay.
Yeah. Good afternoon, Miss Christabel. I am Dea Istifa Ayu, student from Public Health Department. I want to ask you about your explanation from the several barriers that exist. Are there certain culture or customary values in Malawi that have an impact on efforts to improve the quality of maternal and child health there? If there was sociocultural barriers, are there any special efforts by the stakeholder in dealing with this problem? Thank you.
Okay. Thank you so much. Yes. Indeed, probably I didn't spend time explaining that we have a lot of social cultural barriers when it comes to maternal service use. And usually this is coming from old women, old women who believe in using traditional medicine, but also not just using traditional medicine. There are also some kind of cultural beliefs to say when you're giving birth, your in-law, mother-in-law should be there experiencing the birth. If the baby is not born, then maybe it's not from your husband. All those things are there. So these may be some kind of hindrances to service use. But like I said, we are working together with the cultural custodians. So these cultural custodians, because the cultural issues are so vast, since the country is divided into different tribes, so they are so vast. So what is happening is for each tribe or for each community with such kind of myths and beliefs, what is happening is the government works directly with the cultural custodians, traditional leaders or religious leaders, but also these valued old women and even old men in the community to identify the hindrances together and work towards addressing that. And it has to be an agreement made by the whole community. Okay, so that's what is happening at the moment. So we've seen a lot of strides as well, because like, for example, the issue about the bylaws having sanctions. If you don't go and deliver in a facility, you will be sanctioned. The issue that I talked about earlier on, that came from these people, from the community itself. They made this particular suggestion. Yeah. I hope I've answered the question.
Thank you very much, Ms. Christabel. Yes. Yes. Ladies and gentlemen, finally, we are come to the last agenda. We would like to say thank you very much for the Miss Christabel for your knowledge, information, sharing, and thank you to give the knowledge for all my students in Public Health Universitas Negeri Semarang. Okay, Miss Lala.
Okay, thank you, Miss Nursiam, and also thank you so much for Miss Christabel. It was very interesting for sharing to my student and also my colleagues in here. And yeah, hopefully we can collaborate more, maybe in the same platform like this, like visiting lecture, or maybe we can collaborate with research, or maybe Miss Arulita, maybe with her question about the research and data. Yeah, maybe
Yes.
she interested. Maybe yeah, we
Yes.
can talk later.
Mm.
Okay, and thank you for all participants in this evening. Thank you for your attendance and thank you for participating in this lecture. And hopefully it gives you a benefit, yeah, for all of you. Okay, I think it's off. Do you want to say thank you maybe to Miss Christabel? Just turn on your microphone and say thank you to Miss Christabel.
Thank
Thank
you, Miss
you, Miss
Christabel.
Christabel.
Thank you, Miss Christabel.
Miss.
Thank you, Miss.
Okay. Christabel, do you want to?
Welcome. Thank you so much. That was so kind of you.
Okay. Okay. I think it's enough. We already 1.5 lecture in here, and so I think it's enough.
Bulala,
Yeah. Sorry.
after you, we will share the link of certificate.
Oh, okay. Yeah, I'm sorry. And yeah, thank you. And Mr. Lukman will give some something to Miss Christabel. Okay. Okay, Mr. Lukman.
Not for Miss Christabel, Bulala, for student, for issuing the certificate, sorry.
Oh, sorry. Yeah, we already prepared. So sorry.
That's fine.
Yeah, it is a announcement to the participant.
Yes.
Okay.
Okay, to all students here, if you want to request the certificate, please fill the link on the screen with bit.do/e-certificate1, and please write your email correctly, because this e-certificate will be sent to your email address, and the link is active only for 60 minutes after this meeting is over. I will rewrite again in the chat menu so you can copy it and just click to the next browser. Thank you, Bulala.
Okay.
Give it back to you.
Lukman.
Or maybe we can take picture together, Bulala. All students here on the camera. I will take picture from here.
Okay.
Slide 1, please. Smile. 1 and 2 and 3. The second layer. Please smile. Please on your camera. 1, 2, 3. The third layer. Please on your camera. 1, 2, and Rizky Amalia, your camera is off. Please on. Okay. Fourth layer. Fourth layer is all off here. Okay, 1 and 2 and 3. Okay, this is the last layer. Okay, enough. Bulala.
Okay, thank you. And the announcements already in the chat room. Please to fill it, all the participants. Okay. Yeah. Thank you for all. Thank you for Christabel. And I think it's enough. And Christabel, hopefully I can see you in the next, maybe by virtual or maybe by, directly.
No problem, no problem. And thank you for having me. It has been nice and a good experience. I've liked the interactions that we had and the good questions. And thank you so much for considering me to give this particular lecture. We shall also would like to have one of you as well come and give a lecture here. We can arrange for that. So we need to have these kind of collaborations, these kind of lectures, and sharing experiences is very important, because this is how we learn. And yeah, from what others are doing. Yeah, thank you so much.
Okay, thank you. We will discuss it later again. Okay.
Yes, thank you.
Okay, thank you for all.
Bye-bye.
Over. Bye. Good afternoon.
Thank you, Christabel.
Wabarakatuh.
Untuk para mahasiswa yang ingin e-certificate, please write your email correctly, yes. Do not write your email with the wrong or typo, because the certificate will not be sent to your email. Please write the email correctly. And this link is only active until 4:30. Thank you.
Thank you, Mr.
Okay, see you. I will leave the meeting.